Good morning again and welcome everyone. So glad to have you all here today. Really great turnout. My name is Jonathan Bell. I use he, him pronouns, and I'm from Sacramento State University. Really excited to have such a great turnout. I want to mention just a few important things before we get started. You probably saw that notice when you came in. This meeting is being recorded. The recording of the meeting and the slides will be made available some point after the end of the meeting. In addition to Spanish interpretation, we also have American Sign Language interpretation available. To access the American Sign Language interpretation, please again click the circle at the bottom of your screen, the circle with the lines through it, and you'll be able to get in to see the ASL window there. In addition to that, closed captioning is available. You can find that in your toolbar too. You're looking for the button with the two CCs in there. Throughout the meeting, we want to welcome you to please use the chat today, as I see a lot of people are introducing themselves. Please feel free to use that chat to provide any comments that you have. If you have questions during today, please find the Q&A window in Zoom. That's also in that toolbar. It says Q&A, it has a little question mark in it. Please place any questions you have in there. CDPH will not be responding directly to comments or questions during this meeting, but we're going to make sure that we collect everything that anyone says and provide it to them verbatim after the meeting concludes. So after CDPH's presentation, we're going to have about 60 minutes for public comment. When we get there, you'll be able to raise your hand and come off of mute and provide comments during that time. I think we're going to be able to give each person about 2 minutes to speak, and I'll have a little bit more information for you when we get to that point. For now, I'm going to pass the mic over to Trudy to give us a little bit more information about today's meeting.
Hi, good morning, and thank you, Jonathan. So for folks that don't know me, my name is Trudy Raimundo, she, her. I have been working with CDPH since the early start of COVID, and I have had the privilege of leading a lot of their BHSA-related efforts on behalf of the department. And so wanted to give you a quick overview of the agenda for today. We've covered the welcome and logistics. We will be covering an overview of our Phase 2 guide, which I can see from just the number of participants we have today has been of great interest for our community across the state. We're going to talk a little more about funding and investments that we are providing to really maximize local reach of our statewide strategies and policies across the state and into our communities. As Jonathan mentioned, we really want to spend the majority of our time today on public comment because for me, that is the most important part of the conversation today, is being able to hear from you, any feedback that you've got, questions, concerns, all of those things, because we want to be mindful of the fact that you are the experts on the ground. And so we want to take that feedback and really think through how we continue to evolve our Phase 2 guide. Next slide, please. Next slide. So I want to provide just a quick overview of the BHSA funding, and more concertedly, the 4% that is going to now the California Department of Public Health in order to administer the statewide prevention services, really focused on reducing the risk of people developing mental health conditions or substance use disorders. Just highlighting that written into statute is that 51% of the funding must be used to serve populations that are 25 years and under. And hopefully the strategies and the components that we will be presenting today really showcase how we are looking to target this population. Next slide, please. So just a few things to cover in terms of statutorily what we are going to be required to do. We must incorporate evidence-based or are promising community-defined practices, which I'm really encouraged about. I think ensuring cultural relevancy into all of the work that we do is critical and important. We have to be meeting one or more of the following that are written into statute, so benefit the entire population, county or particular community. And so we have designed a series of strategies that are both at the statewide level, but also looking at how do we address it amongst particular communities. Serving populations that are at elevated risk, and really aiming to reduce stigma. This is something that I really want to note, because this idea of reducing stigma and discrimination, especially when it comes to seeking help, and seeking help when you're ready to seek help. So being able to meet folks where they are at is foundational to all of the work that we are going to be proposing today. Certainly serving those populations disproportionately impacted by systemic racism and discrimination. And ultimately, our outcomes are really looking at preventing suicide, self-harm, or overdose. The one thing I do want to also reiterate is that the funding that is being provided to CDPH for population-based prevention cannot be used for early intervention, diagnostic services, or unique treatment for individuals. Next slide, please. So I'm going to give you a quick overview of some of the foundational aspects. Yes.
Could I interrupt you for 1 second, Trudy? I just wanted to remind you that we have to introduce Dr. Pong and Christine.
Thank you for that. I am so sorry. I just dove right into it. I would like to, before I move on, I'd like to introduce Dr. Erica Pan, our State Public Health Officer and Director, and Christine Theodore, our Assistant Director for CDPH, to provide some opening comments. Apologies.
No problem, Trudy. Thank you. And I know everyone actually is really much more interested in what you are diving into. But just briefly, I wanted to welcome you all, and really honored to join this group today. I see, yes, the numbers just keep climbing. So I'm really pleased to see so much interest. I'm the director of the California Department of Public Health and the State Public Health Officer. I've been in this role since February. And I oversee our efforts to protect and promote the health of all Californians. And we have a deep commitment to equity, transparency, and really importantly, especially for this, an opportunity like this, to hear from all of you, our partnership with community partners. So as you are already starting to hear, today will be a really important opportunity that we're providing information on our Behavioral Health Services Act statewide population-based prevention programs Phase 2 guide that you started to get a great overview from with Trudy. And this is our second public webinar and our first Phase 2 guide presentation about this. So we spent a lot of time and a lot of work, as you all know, over the last sort of year and longer to get to this point. And we really appreciate all the input we've gotten so far. And we're really excited in public health to elevate behavioral health and prevention as a public health priority in this space. So again, looking forward to working with all of you to coordinate these efforts that are more upstream and prevention to promote well-being. And also joining us today to help welcome you is Christine Theodore, our Assistant Director. And just want to thank, while I'm here, our team, including Trudy and Kalandra and Julie Nagasako and Ashley Mills, and just a huge team that has been behind the scenes working really hard on this guide, and that is looking forward to working with all of you as we implement this and move forward. So I'm going to pass it over to Christina to give us a brief project overview. Thank you.
Thanks, Erica, and thank you all for joining us today. We have over and climbing 800 and climbing. So I'm really pleased that many folks are tuning in today. I'm really honored to join you as the Assistant Director of the California Department of Public Health. And in this role, I also support the department's effort to protect and promote the health of all Californians with our deep commitment to equity, transparency, and partnership. BHSA presents a unique opportunity to expand behavioral health services in ways that are community-driven and culturally grounded. This is an opportunity for CDPH in California to do things a little differently, engaging with you often as we work to transform behavioral health and prevention. We want to hear from you what's working, what's missing, and how we can do better. CDPH's population-based behavioral health prevention strategy is part of a statewide effort to build a stronger and more equitable behavioral health system, one that brings hope, support,
You'll need to unlock your iPhone first.
and care to every community. Our CDPH team leading the planning process for BHSA Population-Based Prevention will provide an overview of the second phase of guidance for CDPH's BHSA Population-Based Prevention Program. As many of you chimed in, our first phase was rooted in a comprehensive community engagement where CDPH conducted planning that brought together information about existing landscape of behavioral health initiatives and opportunities, such as activities implemented through MHSA, prevention, and early intervention. We reviewed reports and research and data analysis to understand the trends in suicide, self-harm, and overdose. And we also conducted interviews with subject matter experts and facilitation of engagement events to garner input from community partners. This Phase 2 guide is intended to act as a complement to the first phase of that guidance that was released in June of this year. And the Phase 2 provides operational and administrative details on CDPH's planned strategies, funding levels, and activities. So I'm really, again, thankful for all of you and participating today. I'm really grateful to the team that has done so much work to get us to this point. And I'm going to turn it back to Trudy to dive into the content a little bit more. Thank you.
All right. Thank you, Erica and Christine. And obviously, as you can tell, I am just so excited to finally reach this milestone and be able to have this conversation with all of you. So again, apologies for just jumping right in, but we'll go ahead and jump right in. So next slide, please. So a few things I wanted to note overall about our Phase 2 Population-Based Prevention Program Guide. So a few things that really went into how we are crafting it today. It integrates a lot of the comments that we received when we presented our Phase 1 guide. And so just wanting to be mindful of that. More importantly, our Phase 2 now really addresses the operational and administrative components that we are proposing to put into place to really meet all of the intended objectives, the goals and the outcomes, and certainly how we're going to follow through on what is statutorily required. It's going to be guided by a lot of community and partner input. So all of the feedback that we are going to hear today is going to be so important to how we shape our Phase 2 guide. It's also guided by a lot of input that we are getting from stakeholders across the behavioral health system. And so we'll talk a little more about how we plan to work across the full spectrum. It includes a lot of the implementation activities that we are proposing within each of the 6 components that comprise our full guide. And then it's going to ultimately set the statewide direction and strategies. And we're going to talk a little more about where we are investing in opportunities to expand local reach of these statewide strategies and policies. Next slide, please. So this BHSA population-based prevention is really going to be our Phase 2 is going to be coordinated and combined with our Phase 1 guide to ultimately develop what we are calling the final plan. And that final plan is going to cover the period from July 1st of 26 through June 30th of 29. And we were very intentional with that timeline because we really wanted to ensure that we were working in alignment and being able to integrate existing behavioral health related efforts, both at the state and the local level as well. Just being mindful also that you may see future updates of our final plan because we want to make sure that we are providing additional clarity where needed. We want to ensure that we are evaluating all of the work that we are doing, and to that extent, where we need to course correct or provide additional amendments to the guide, we will be doing that, as well as anytime we may need to address any emerging needs and issues. I think we can all definitely say that what is happening right now at the federal level continues to change our landscape nearly on a daily basis. So we want to ensure that we are both flexible and adaptable as part of that ever-changing landscape. Next slide, please. So a few things that I wanted to go over in terms of our priority populations for strategic investment. And I use the word strategic investment because this is really where we are honing in on funding investments. So this is the list that we have right now: Black, Indigenous, and other people of color, children, youth, and families, immigrant and refugee populations, our LGBTQIA+ populations, older adults, tribes, and veterans. And one thing I do want to note is that the list that we're providing to you is just in alphabetical order and certainly not intended to be some sense of prioritization. And we really honed in on these priority populations based on a few things. So we continue to look, even after the Phase 1 guide, we really continued to look at the data that was driving suicide, self-harm, and overdose across our varied races, ethnicities, and cultures. We really wanted to make sure that our investments were filling gaps in our existing system. And we also really were mindful of where, as I mentioned before, federal policy and the federal landscape are creating just additional vulnerabilities in many of our populations. And so we definitely took that into consideration as we developed these priority populations for strategic investment. Next slide, please. So the guide also, just as a reminder, stands in alignment with the 14 statewide behavioral health goals. These are goals that really are driving how we are targeting much of our investment. The one thing I do want to note in terms of these goals is that equity is foundational to all of these goals. And we acknowledge that it's not going to be just BHSA funding alone that's going to help us as a state advance many of these goals for improvement and these goals for reduction. So what we have created in order to really advance these goals is thinking through how do we work both across the state and the local level, because we know it's going to take cross-sectoral approaches, real collaboration and integration in order for us to meet these goals. Next slide, please. An alignment across the behavioral health system. This is something that we have been working very closely on. Again, we know even within public health, we will not be able to do this work alone. So there is a huge emphasis in our Phase 2 guide about how we are intending to work across the behavioral health system and working very closely with all of our colleagues, especially DHCS, because as you can see here, there is close alignment and integration from both the prevention side to early intervention. So what we want to do is ensure that we are creating a seamless system for the community. Another couple of things is I had the privilege of attending a behavioral health task force meeting yesterday. And that task force meeting really highlighted the need to take a very strong, integrated, systemic approach to all of these issues. And so our effort is really centered on that, because what we don't want to happen, and this has been part of something that has stuck with me through this entire effort, is early on in our conversations with community, someone had mentioned that they felt like they needed to choose between prevention or early intervention or treatment. And that is certainly never the goal of what we want to accomplish. We want to ensure that we're creating a system that meets individuals where they are at and not forcing them into separate buckets, because we know individuals evolve, they're not static. And so the effort really around all of this alignment is to create a seamless system for you and the community. Next slide, please. So another thing I want to highlight is we have a lot of great and existing expertise within CDPH. We highlighted it often in our early convenings and conversations with the community. And so this is just a snapshot of all of the existing expertise, resources, and initiatives that we are really leveraging to ensure that we are taking a very strategic approach through all of this effort. The one thing I also want to highlight is, as you know, public health is acknowledged to have really great expertise in the areas of data and evaluation. And so we are planning to lean very heavily on that experience and that expertise, because the evaluation and the monitoring of our work, as you'll hear later, is critical to everything that we are going to be doing, because we want to ensure that we are transparent with the community on what works, on what doesn't, and really just ensuring that we are meeting all of those accountability and responsibility measures. Next slide. If you have not had an opportunity to read our Phase 2 guide, which was posted earlier this week, part of our effort also is to create a new Office of Social and Behavioral Health. As the previous slide had alluded to, there's a lot of existing expertise and programs within CDPH. And so by creating this new office, really the vision is to create a much more coordinated and centralized approach to all of our work. We want to ensure that we have strong leadership that can work across all of the system partners. We also want to create efficiencies as part of our planning. The dollars that have been invested for CDPH population-based prevention is limited. It's not enough to really think about how do we ensure coverage across the state. And so we want to make sure that we are using those dollars in the most strategic manner possible. And as Dr. Pan had noted, I think this really helps to promote behavioral health as a public health priority. And by doing that, this creates not just visibility, but a real call to action for all of us, both in public health, behavioral health, across all of our system partners and our community. We really want to use this as a way for a call to action that we all have to come together to achieve those goals. Next slide, please. And so now I am going to turn it over to my colleague, Calandra Park, who's going to talk a little more and dive deeper into the 6 program components that we've got.
Thanks, Trudy. Good morning, everybody. My name is Calandra Park. I am one of the managers here in the Office of Policy and Planning at CDPH and part of the BHSA planning team. So it's very nice to be here. Really pleased with the turnout. I'm going to dive into the more nitty-gritty details, probably, that a lot of people are curious to hear more about. Next slide, please. So as Trudy mentioned, these are the 6 population-based prevention program components. We'll go into each of these in more detail in subsequent slides, but just as a quick overview and snapshot, the 6 components are the statewide policy initiatives, essentially developing statewide policy platforms. There is a focused statewide behavioral health prevention strategies set, like a set of strategies to prevent suicide and self-harm and overdose. And then there's a campaign component, a training and technical assistance component, community engagement and coalition building, as well as data and evaluation. Next slide, please. So when it comes to statewide policy initiatives, CDPH is going to be focusing on developing expertise and resources to address emerging behavioral health issues. So we know that there are emerging substance use and behavioral health threats. As Trudy mentioned earlier, there are also the emerging impacts of federal policy that we want to be nimble enough to respond to and recognize its impact throughout the state. And just as an example of some policy recommendations that we would like to prioritize include AB 1282, which is the impact of social media on youth, and as well as the recently passed SB 243, which is intended to implement safeguards for chat platforms when issues such as suicidal ideation, self-harm, and suicide come up, and that these platforms will be required to develop a protocol for safety. Next slide, please. So statewide prevention strategies, again, as Trudy mentioned earlier, there are many different existing plans and initiatives that we looked at and wanted to leverage and elevate and inform the work that we're doing so that we're not recreating the wheel or duplicating effort. So just as a highlight again here, there is the Strategic Plan for Suicide Prevention, the Violence Prevention Initiative and Roadmap, the Overdose Prevention Initiative, the 988 Blueprint, the Master Plan on Aging, as well as the resources and initiatives from SAMHSA, the federal agency. So just as an example, on the right side, you'll see some, just a list of examples. And again, I want to emphasize that these are examples, but ideas and strategies such as ideas and strategies that are addressing lethal means safety and harm reduction, elevating cultural and social connections, socio-emotional learning, stigma and discrimination reduction, policy systems and environmental change, early childhood and parenting support, as well as community-defined evidence-based practices. So we know that a lot of these strategies were elevated, again, as Trudy mentioned earlier, through the input of many different individuals throughout the state, from community-based organizations, from programs, individuals of lived experience, as well as many other avenues of input. Next slide, please. The next component that we'll talk about are statewide awareness campaigns. So it's a two-pronged approach here. So on the left, you'll see that there is a plan and a strategy to leverage existing assets. So we have 4 campaigns that we will continue to support and work on more localized strategies here. There's Never a Bother, Take Space to Pause, Live Beyond, and Facts Fight Fentanyl. And then on the right side, we are planning to develop new campaigns focused on suicide and self-harm, basically to increase awareness and public education on suicide and self-harm and how they can seek help. Essentially, it's to reduce stigma. And then the next new campaign that we would like to work on is focused on 988. This is the national resource. However, we want to elevate 988 here in California and recognize that some of the services have been maybe somewhat fragmented or disjointed, and we would like to kind of coalesce and bring those services together and offer additional crisis-based services and resources through 988. And then the last new campaign is the Substance Use Disorder Prevention Campaign, also to raise awareness about substance use disorder and reduce stigma and misconceptions. Next slide, please. The next component, program component, is training and technical assistance. We know that TTA, as it's also known, is vital for the success of CDPH programming and implementation. We want to be able to equip folks around the state and other prevention partners, educators, community members, leaders with the tools to promote behavioral health awareness, reduce stigma, prevent suicide, self-harm, and overdose, particularly among priority populations. So again, these are examples listed on the slides. We want to make sure that TTA is provided in unique areas. So as an example, we want to promote strategies focused on positive childhood experiences, behavioral health literacy curricula to increase knowledge and skills related to mental and behavioral well-being, as well as trauma-responsive practices for the early childhood care community. So CDPH is also planning to work with other statewide entities that could deliver unique technical assistance to support behavioral health prevention in priority populations, such as veterans and older adults. So again, these are examples to give folks a concrete sense or an idea of what we are proposing. Next slide, please. The last two components are community engagement and coalition building, as well as data and evaluation. So we know this work could not be done without the critical and absolute imperative input from the community. And so to that end, we're developing 3 different opportunities for folks to get engaged and provide feedback and be a part of the overall process. The first is the implementation work group. This work group will inform CDPH BHSA statewide planning. This group is intended to just elevate issues. California is a big state. There's a variety of issues and priorities. We have rural, we have urban, we have a diverse racial makeup here in California. So we want to make sure that this is a group that is elevating local issues and understanding and looking at solutions as a way forward. Another community engagement opportunity would be the CDEP Advisory Committee. The CDEPs are the Community Defined Evidence-Based Practices, and this will be a committee that is solely focused on the CDEP work that's being done. And then the last engagement opportunity is the Youth and Family Engagement Network. So in the statute, we are required to dedicate at least 51% of the funding to services related to youth. And so to that end, we wanted to elevate the opportunity for youth and family to provide input, share what's working, what's not working, elevate needs and priorities through this network. And then last but not least, on the right-hand side, absolutely not least, is data and evaluation. As Trudy mentioned earlier, we want to make sure that we are accountable for the work that we are doing. We would like to develop a robust monitoring and evaluation strategy and framework for the work that we're doing. We want to be able to look at the statewide impact, what's working, what's not working, what needs to be tweaked, what needs to be addressed, what needs to be elevated. But we're also hoping to align the system of metrics across the state. So this means working with our sister agencies such as BHCS and other entities to make sure that we are all on the same page and moving forward together. We would also like to utilize the data through the lens of health equity. As Trudy emphasized also, health equity is absolutely foundational to the work that we are doing, and we want to be able to identify disparities in the work that we're doing. And to that end, data disaggregation will help facilitate that work. Next slide, please. Okay, so the next section of slides will talk about the funding to mobilize local reach of statewide strategies and policy. So next slide, please. So just as a loose framework in terms of our approach to funding at the local level, really it's intended to mobilize the work that's going to happen at the local level. So we're investing in infrastructure. We want to make sure that there's a strong system of just support, implementation, capacity, staffing, whatever we need to do to make sure that there's strong coordination across the behavioral health prevention continuum. And then there's the cross-cutting efforts. So we are elevating behavioral health in the public health space. This is new. This is different. This is a paradigm shift. And this is something that it's going to take a lot of coordinated work and synergy, coordination at a lot of different levels, locally, regionally, statewide. And we want to make sure that there are cross-cutting efforts across the board. And then ultimately, the goal really is systems change, right? We want to make sure that there's multi-sector collaboration, blending and braiding of funds. We want to have an upstream focus looking at the social determinants of health. And again, really elevating behavioral health and public health. That alone is systems change right there. Next slide, please. Okay, so this is a summary slide here that provides an overview of the different strategies at the local level, and then we'll go into a little bit more detail in the next few slides. So on the left is the CBOs and tribes would be our partners in implementing this at the local level. So we have CDEPs, the Community Defined Evidence-Based Practices, Trusted Messenger Grants, 988, the Regional Policy Research and Development, as well as the regional approaches for implementation of focused set of strategies. And on the right side, training and technical assistance. Again, we are elevating some key populations here: older adult behavioral health, the veterans, 988, regional approaches, train the trainer models, CDEP, and tribal engagement. Next slide, please. So community-defined evidence-based practices. This program is intended to help scale some of the work that's already that has been done to some degree with high priority populations and marginalized communities. We want to focus on effectiveness and racial equity and sustainability. And we want to look at those communities that have been historically unserved, underserved, and inappropriately served when it comes to behavioral health. So the purpose of this grant program is to improve access to behavioral health prevention and resiliency. Next slide, please. The Trusted Messenger Campaign Grant Program. Trusted messengers, just like the name implies, they play a crucial role in bridging communication gaps and improving health outcomes. These are folks that connect with their own communities. These are folks that people trust, They help foster empathy and understanding and respect for health information that's being shared in a way that's very localized and tailored to their immediate community and their spheres of influence. So they so then by building trust, these messengers, can deliver public health messages that are more likely to be heard and accepted and acted upon, and ultimately in the long run, improving health outcomes. Next slide, please. The 988 and Suicide Crisis Lifeline Outreach Campaign Grant Program. So this priority here is essentially to identify the knowledge, attitudes, beliefs, and perceptions around 988 and accessing crisis services in general. As I mentioned earlier, we know that 988 is a national resource, but it is also something here that's available at the state that may not have its full, that can be accessed more frequently and that can be accessed more frequently. So we want to look at what the barriers are and what's preventing folks from accessing that. We want to be able to develop culturally relevant messages and encourage the use of 988. We want to tailor the messaging. We want to align with the infrastructure that's already in place and also develop resources and referrals that are related to the campaign messaging as well as crisis services throughout the state. Next slide, please. Okay, and then the next two components are focused on regional approaches. So the regional policy research and development here, this aims to address health inequities that are quite, specific to specific regions around the state. We know, again, that California is a large state with a lot of different needs and priorities and populations, resources, and capacities. So we want to be able to support the work that focuses on community engagement, looking at what's working and what's not, and looking at implementation tools that would be relevant and appropriate for the work that's happening, and also looking at unintended outcomes. We know that there's also varying capacity and resources. So we would love to see community-defined policy recommendations that acknowledge all of these components and pieces and coming up with strategies that address the impacts of social determinants on behavioral health, and always focusing on stigma reduction, stigma reduction and promotion of mental well-being and resilience. Next slide, please. And related to that, we would also love to see, regional implementation of focused strategies. So again, we know that the regional approach has many benefits. California has a lot of diverse needs. We would like to see tailored efforts to unique regional characteristics, promote strategic and effective, resource sharing and collaboration to leverage limited resources that are out there, and also essentially encourage peer learning in these regions and help share best practices among the partners, and also just facilitating deeper engagement with the LHJs in these regions to assess community needs and determine strategies. So we know that there are different demographics and health experiences, in these different regions throughout California. So again, we would love to see just strategic resource pooling, peer learning, and just leveraging your resources as much as possible. Next slide, please. Training and technical assistance grants. Just like it says here, as we went over earlier, it really is to provide support around specific strategies and specific implementation efforts. We want to strengthen local capacity and improve equitable access. We want to build trust. Focus areas, as you see on the slide here, include older adult behavioral health, veterans, the 988 crisis services, regional approaches, and train the trainer models. And now I will turn it back over to Trudy.
Thank you, Calandra. Next slide, please. So I wanted to talk a little bit about two other buckets of funding that we are investing in as part of our Phase 2 guide. The first is a dedicated pot of money for tribes. We really want to, this dedicated pot of funding is really just looking at acknowledging and specifically addressing what we have seen as the persistent socioeconomic disparities faced by our Native American communities. I've been It's been a privilege to be able to host a formal tribal consultation with our tribes because we want to make sure that this process, as we go through it, is informed by our tribes and that it remains accessible, it remains inclusive, but really is intended to help meet and their needs so that it acknowledges their sovereign status and really their wisdom to be able to tailor strategies specific for tribes. The other pot of money that I wanted to go over is some dedicated funding to support our local health jurisdiction partners. They are going to be asked with these dollars to really do three things. Number one, act as local prevention coordinators. And so what we'll discuss in the next couple of slides is this idea of having them convene. As you saw, we are making available, we are proposing a variety of funding buckets to really think about implementation of our statewide strategies. And so we want to be able to convene a table that brings all of those funded partners and other important stakeholders to the table to ensure that there is visibility and alignment across all of this work. They're also going to be tasked with leading the development or update of local suicide plans. I think as part of our research, we've seen that there are 17 existing plans across the state. And so really want to think about how do we leverage this exciting work across the state. And then really, as part of our kind of efforts to continue to integrate, align, not just at the state level, but at the local level as well. Integration of these convenings and the data and the needs and the assets that are identified as part of these convenings, ultimately into the local health jurisdiction-led community health assessments and community health improvement plans. And if folks have not been tracking the work that we have been doing, again, with our DHCS colleagues around population health. We are looking at instituting requirements that LHJs would be required to do a CHA and a CHIP by 2028 and 2029. So it's really thinking about long-term, how do we integrate all of this behavioral health related work into the community health assessment and community health improvement process to, again, avoid anytime we can duplication, community fatigue, but really leverage the strong backbone that I think LHJs create as they do their CHA and CHIP process. Next slide, please. So for the tribal grant program, so our eligibility right now is for federally recognized tribes, Indian health clinics, and urban Indian organizations. And these are, again, things that we've been working very closely with our tribes and tribal partners on in terms of defining all of these things. Again, as I said, the purpose is really just to acknowledge and formalize the government-to-government relationship and approach, and really just acknowledging the tribal sovereignty. We think it will provide access to crucial resources that I think we can all acknowledge have been incredibly limited or denied in the past. And it allows our tribes to create really tailored approaches for them and really just acknowledges their wisdom in being able to clearly identify what works for them. Next slide, please. And so for the local health jurisdiction role, there are three areas where this funding will help support. So again, having them act as conveners at the local level to bring in, to create a table that would bring in all of the funded entities at the local level as well. As part of that approach, we really want to emphasize that these convenings are really intended to just coordinate the resources across the jurisdiction, make sure that we are reducing any sort of duplication or mitigating the risk of duplication, continuing to identify gaps or any emerging issues that result as part of this process. So what we've also included is a list of, at a minimum, entities that will be be required to convene. I want to highlight county behavioral health departments as part of this process, and this is really just an acknowledgement that county behavioral health is part of the current and prior MHSA really led the prevention efforts at the local level. So we want to ensure that there continues to be visibility to all of that prevention programming that has been happening on the ground. We think MCPs play a very critical role across our behavioral health continuum. And so ensuring that they are represented at this table. Tribes, we want to make sure that the voices of tribes are heard and that their needs are heard at the local level. Areas on aging, county veteran services officers, those are part of our priority populations, and we think local areas on agings and certainly county officers are probably the best equipped and most expert to really be able to convey the needs of those special populations, and then including our local education partners and others that are serving children and families. Also, they are strongly encouraged for the LHJs to think about how to incorporate those with lived experience as part of this convening. We know those are critical voices that should be part of the process. On the local suicide prevention plans, it's really honing in on two things. Number one, really looking at the data. So how do we conduct suicide fatality reviews so that local jurisdictions and all of the entities that they're convening truly understand the impact of suicide in their jurisdiction, and then based on that data, developing data-driven and data-informed strategies, again, in coordination with the stakeholders at the table. And then ultimately, this vision for alignment at the local level, really thinking through, how do we make sure that we are avoiding any sort of redundancy and community fatigue. So really thinking through how do you integrate all of this work over this first 3-year cycle, ultimately into the LHJ community health assessment and community health improvement process by 28 and 29. Next slide, please. So I want to talk a little bit, as we've been saying, we are really focused on this idea of aligning not just at the state level, but at the local level as well. Next slide. So this is just a visual of how we are kind of seeing this alignment work happening. And as you can see in the visual, ultimately, our goal is to integrate all of this BHSA local prevention coordinator into the LHJ CHA and CHIP. Right now, as we stand, we know that there can't be perfect integration because LHJs either are have not started a CHA or CHIP process, but if folks have just a unique understanding of LHJ CHAs and CHIPs, they're not on a consistent synchronized statewide timeline. And so just acknowledging that there are going to be variations across the 61 jurisdictions. But ultimately, the vision, as we create a synchronized system by 28 and 29, that all of this effort really be integrated into the LHJ CHA and CHIP. And then again, just standardizing across the state starting in 2028. Next slide, please. And so from a timing perspective, this is kind of what we are expecting to see. So starting in June, July of 2026, our LHJ partners will start to begin these coordination efforts around BHSA prevention. This is timed along with the first local behavioral health integrated plans being due in June of 26. By December of 28, what we would expect to see is that all of these kind of prevention convenings and coordination really get integrated into the LHJ CHA and CHIP, both in December of 28 and June of 29. And really the idea being that we are intentionally integrating the behavioral health data, behavioral health needs, and the behavioral health assets that are developed as part of this process into those community health assessments and community health improvement plans. Next slide, please. So this is, I think, the most important part of all of this conversation is really the public comment. That is why we wanted to host these webinars, is to get your feedback on all of, not just our guide, but any ideas that we presented before you today. So with that, I'm going to turn it over to Jonathan Bell from CSUS to walk us through facilitation of public comment.
Thank you very much, Trudy. All right, really quickly, just a few guidelines for everyone to consider. First off, equity. Please be mindful of whose voices are being heard and make space for others. Importantly, this will include trying to stick to our time limit of 2 minutes for comments. We have over 800 people in attendance today. Making room for as many people to speak as possible is important. Secondly, please keep respect in mind. Speak to one another with care, even if you disagree. Stay focused on the topic at hand. Use non-stigmatizing language when you're speaking. Focus on people first rather than labels. Avoid stereotypes and speak in ways that honor folks' dignity and strengths. Please welcome new ideas. And lastly, practice active listening, which again includes honoring speakers' time and perspective. Next slide, please. Just a couple different ways for you to provide public comment. You are free to continue to use the chat for comments, the Q&A for questions. There is a public forum, the Microsoft forum, which the link I think has been shared in chat. You can provide your comments there, or you can speak verbally here during the webinar. In order to do that, please use the raise hand feature. You'll find that in your toolbar. I will call on everybody in the order that you have raised your hand. And I will say in advance that I will call on you using your name, and I apologize if I mispronounce your name. Please introduce yourself before sharing your comment. And the last thing I want to mention is that if we receive comments in Spanish and you would prefer to hear the English translation of that comment, you're able to use the interpretation button at the bottom of your screen. Click that, click the English channel, and you should be able to hear an English translation of any Spanish comments that come through. And I guess the last thing I'll say is that you will see a timer on your screen. As soon as you start your comment, we'll have that timer going so you have a sense of how much time you have left. All right, I think that's it. Oh, I'm sorry, and I need to say this aloud because phone participants won't be able to see it. If you are calling in from a phone and you would like to speak, press star and the number 9 to raise your hand. Then press star and the number 6 to mute and unmute yourself. All right, that's it. Mia Cooper-Kong, you are the first person. Are you able to unmute?
Hi, can you hear me?
Yes, we can. Go ahead.
Thank you. Hi, my name is Mia Cooper-Khan. I'm the Senior Manager of Integrated Health at Alameda Health Consortium in Alameda County. Just thank you for the presentation today and the additional information. We hope that the Department of Public Health will allocate a significant percentage of this prevention funding to support local initiatives and local CBOs, including federally qualified health centers, through the options that were named today, including the CDEPs, the local messenger grants, etc. I didn't see estimated kind of numbers in terms of the how much would be allocated in each of those buckets, but just wanted to name that here in Alameda County with the transition to BHSA, we're hearing from our behavioral health department that they're forecasting a $75.5 million deficit in the behavioral health services and supports category for starting fiscal year 26. And we are expecting to see an elimination and reduction in a lot of the existing prevention programming. So just wanted to name that and appreciating any future guidance coming out around and more specifics around the local funding opportunities, including the community-defined practices. Thank you so much.
Great. Thank you very much, Mia. Next on the list, I have Angela. Are you able to unmute, Angela?
Yes, thank you. Angela
All right.
Vasquez, Advocacy Director over Mental Health at the Children's Partnership. First, want to thank the department for this more detailed plan. This feels very responsive to stakeholders' feedback in the past, asking for a lot more detail on your plan. In particular, want to really applaud you for considering and responding to the feedback for more for a plan that has a local strategy for implementation of upstream prevention for behavioral health in California. One note is that I think we would very much like to see more detail on the department's strategy for children and youth, particularly since the statute requires that CDPH spend 51% of its efforts on children and youth. And so would very much love to hear more about where those investments, particularly for children and youth, will come. And then also want to just reemphasize the importance of this local strategy. Would love to hear more of the rationale behind having the local strategy be almost equivalent to the statewide awareness campaigns, just given the current context, as you heard in the prior comment before, that counties, their local jurisdictions, CBOs are entering an even greater phase of scarcity, and especially with increasing federal limits on healthcare resources. Really want to encourage the department to think about how, especially in these first couple of years of implementation of Prop 1, how they might strengthen the local strategy to backfill the infrastructure that counties have built up over the last 20 years around prevention. Thank you.
Great. Thank you very much, Angela. Next on the list is Joel. Joel, are you able to come off of mute?
Yes, I am. Thank you very much. Thank you very much.
Yes.
Thank you. Joel Baum, he, him pronouns. I'm with Safe Passages, which is one of the organizations that make up the CRDP, the Reducing Disparities Project. Echoing others, want to appreciate the presentation and the information being provided. I also appreciate the opportunities for engagement. Would have loved a little more time to digest the document, but I know we have until December to give you our comments. I want to uplift, I guess, the emphasis on equity. And while, of course, it's applauded, I'd like to hear a little bit more or see a little bit more actionable ways in which equity is going to be incorporated and integrated into the plan. In my initial reading, it felt a little bit layered on top of. I know it's mentioned throughout, but I want to see something that's actionable. What does it look like for the department to actively ensure equity, to look at community voices, to gauge the degrees to which equitable practices are in place? That's one piece. And then the other thing I'd like to emphasize, and I very much love hearing CDEPs being mentioned so frequently. And in fact, I would like us to make sure we keep in mind that when we talk about CDEPs and evidence-based practices, as if CDEPs are not evidence-based, they are. And in fact, there's fabulous and very rigorous research that points to their effectiveness. I want to make sure they're not seen as sort of a second-class citizen at the table. CDEPs are profoundly impactful and have demonstrated both anecdotally, but also quite rigorously in evaluation. So thank you very much.
Thank you, Joel. Next on my list, it looks like Alberto. Alberto, are you able to come off of mute?
I think I am. Can you hear me?
Yep. Yes, we can.
My name is Alberto Perez. I'm the program manager of the Prevention Early Intervention Program here in La Clínica de la Raza in Oakland. Also want to appreciate all the information, the presentation, really, really wonderful work. So really want to thank you all for that. And I have a couple of comments. One of them is related to the priority populations list. Appreciate you including some of those categories. I see you were courageous in some of the wording you used, and still I feel like linguistic minorities were not in there, and I would love to see that included explicitly. Language is a huge factor in access to services and outcomes, and our communities and our organizations are really focused on ensuring that those communities have services in the languages that they prefer. And so I think including them as a priority population will be good. And the other piece of it is, we're also part of the CRDP family, California Reducing Disparities Project. We've already demonstrated that we are effective, just as Joel before me alluded. We have a lot of research evaluation that was done for the past 5 years at least that proves that we are effective in the work we do. And so I would love to see more support for our family of organizations that are delivering community-defined evidence practices. I was mentioning there, but I feel like we do the work, and not we only we provide the services effectively. We in fact helped the state and the institutions in reducing cost. There's a wonderful paper that was written by Loyola Marymount. I hope you get a chance to read it. That proves that we're a good investment, and so I want to see that taken into consideration when thinking of our programs. And that's it. Thank you.
All right. Great. Thank you, Alberto. Next on my list, it looks like the Priya. Priya, are you able to come off of mute?
Yes, can you hear me?
Yes, we can.
Hey, thanks. I'm Priya Cannell. I am the Behavioral Health Services Act Coordinator for Nevada County Behavioral Health. And thank you again for your presentation and clarity as to the Phase 2 plan. I have two major points. One, really want to encourage CDPH to consider expanding eligibility of the CBO grant bucket to local health jurisdictions, such as county public health departments in Nevada County. I'm not exactly sure how the $12 million local health jurisdiction bucket will be administered across health jurisdictions, but if we utilize the BHSA percentage allocations that we currently use, that would look like something like $29,000 allocated to Nevada County of the local health jurisdiction allocations. For context, currently we fund our public health department to the tune of nearly $150,000 annually. I know those are small numbers, but we're a small county, and there are no other CBOs in our community who provide this type of prevention-based work. And our public health department has been doing this work for decades. We have no federally recognized tribe as well. So my fear is by limiting that bucket to only CBOs, that small rural communities and counties will be left in the dust, where their public health departments are holding most of this work in these small communities, that they'll be shut out of this bucket entirely. And so I really encourage and urge CDPH to consider that bucket a little bit more carefully with regard to especially small rural counties. And secondly, just would love to see more detail as to where some of these funding buckets crosswalk to. For example, the Trusted Messenger grants, does that fall under the CBO grants bucket, or does that fall into the tribal grants bucket? So some more clarity from the slides as compared to the pie chart buckets in the plan. Thank you.
All right. Thank you, Priya. Next on my list is Roberto. Roberto, are you able to come off of mute?
Yes, I am. Thank you.
All right, great. Yep.
Hi. So my name is Roberto Velasquez, and I'm president and CEO of Southern Caregiver Resource Center in San Diego. And we are part of the 11 caregiver resource centers in the state of California that work with family caregivers across the spectrum of different illnesses that they're providing care for. And one of the things that I have not seen, and it's not happening in our county here in San Diego, so I'm wondering if this is something that the state is looking into, is the fact that family caregivers are not. I haven't seen anything that indicates that family caregivers are going to be part of this prevention plan, because especially when you're dealing with older adults, whether they have behavioral problems because they have severe mental illness, or because they're dealing with substance abuse, or they're dealing with neurocognitive disorders like Alzheimer's disease or a stroke, and have behavioral issues, there's a family caregiver that's providing that care. And the problem with this plan, if it doesn't include family caregivers, is that there's going to be nobody to help that individual with the interventions, the services, to connect them, to keep them, to maintain them at home. And the other side of it is that the family caregivers themselves develop mental illness, particular depression, and even suicidal ideations as they're caring for chronic neurodegenerative diseases, again, like Alzheimer's, for somebody that they love, and they're themselves becoming ill. And we run programs at Southern Caregiver Resource Center that are helping those individuals, and they're very strong, evidence-based, proven programs that have been eliminated on a local basis. So I'd like to see that on a statewide level, if possible. Thank you.
Thank you very much, Roberto. Next on my list is John. John, are you able to come off of mute?
Hi, yes. Can you hear me?
Yes, we can. Go ahead.
Well, thank you very much. My name is John Goldfinger, and I'm a trauma-focused pediatrician, public health professional, and the CEO of Just Whole Care, a health equity consultancy. Our firm specializes in integrating both clinically and financially behavioral health prevention through early intervention and crisis care, working with CBOs, county behavioral health plans, managed care plans, and increasingly local health jurisdictions and others. So I first want to just thank you for this very thoughtful guide for how CDPH would use these funds, and really very helpful webinar and how you're sharing the information. My first concern is really with regard to HR1 and how CDPH might, in being flexible, which is brilliant, direct some of these investments toward improving resilience in communities that have been so impacted traumatically by federal immigration policy. Could you partner with DHCS to enable the investments like the Trusted Messengers, regional policy, and in TTA to really help build that resilience, and even consider how do we keep people covered by Medi-Cal so that you can have that integration at the local level? We also appreciate your focus on early childhood. It would be great to see evidence and some amount of transparency in terms of technical assistance on how CBOs are meant to grade this funding with essentially dyadic services, which is similar prevention services that overlap: psychoeducation, child development support. It's great to see 988 represented as well. So we really need warm handoffs to consider from primary prevention into crisis systems. As a pediatrician who also led a 988 center in Los Angeles, we just don't see these connections, and would love to see them more. And we appreciate the focus on positive childhood experience. So it'd be great to think about how this will leverage the activity stipends and other work in VH Connect, as well as CDSS rate reforms for kids. Thank you.
Great. Thank you, John. Laurel, like you're up next. Are you able to unmute?
I think I'm unmuted.
Yes,
Am
we
I?
can hear you.
Perfect. Sorry, lingering cold. So I'm Laurel Ben Hamida, and I'm with Muslim American Society Social Services Foundation, which was one of the implementation projects, which actually conducted one of the implementation pilot projects, and REMCO, the Reducing Mental Health Disparities Coalition. I haven't heard post-traumatic stress disorder talked about in this presentation, but I'd like to see it elevated to be explicitly part of the plan, because it tends to be forgotten, partly because it can be caused by experiences later in life. While Proposition 1 sort of zoomed our focus towards schizophrenia and other disorders that may be primarily genetically, biologically based, and not as dependent on what the individual experiences. So PTSD, CDEPs for prevention of PTSD and people who at different ages from infancy up to older age would be something I'd like to see explicitly talked about. I know that you're kind of, well, during the California Reducing Disparities Project, they often talked at the beginning that we're flying the plane while we're building it. Well, you're in the unpleasant position of trying to improve prevention in the state while the feds are trying to disassemble the airplane, if not shoot it down. So I respect all the work that you've done, but I do wonder how the money's going to be allocated. Money's always important. Who's going to decide? And tell us about that process. So thank you so much, and keep up the good work.
Great. Thank you very much, Laurel. Next on my list is Regina. Regina, are you able to come off of mute?
Can you hear me?
Yes, we can. Go ahead.
Wonderful. Okay, thank you so very much for this opportunity. I'm Regina Mason. I'm with the Village Project on the Central Coast in Monterey County, California, and it is a pleasure to be here. I've provided multiple comments in the chat, so I'm going to stick to, I had 9 points that I wanted to make, and the first one is that I appreciate that on page 13 acknowledges the importance of community-defined evidence-based practices as alternatives or complements to traditional EBPs. However, it is critical that these not be treated as, quote, optional reference tools, unquote. I urge the department to prioritize CDEPs as a core strategy and to ensure ongoing funding, technical assistance, and policy integration so that CDEPs are sustained and scaled equitably across the jurisdiction. Another point I wanted to make is that with regards to the advisory committee and equity first approach, this committee must have real decision-making power, ensuring that funding prioritizes and evaluation frameworks reflect community voices and equity principles. And then I fully support the focus on youth and family engagement, especially the 51% funding requirement for the 25 and younger. However, engagement should mean more than participation. It should mean youth leadership. I recommend adding language to ensure youth and families from historically marginalized backgrounds have paid roles in co-designing, implementing, and evaluating these programs. And then lastly, I urge CDPH to embed CDEPs and culturally grounded practices throughout the entire prevention framework, not as a side note, but as a core strategy. And thank you so much for this opportunity to speak.
Thank you very much, Regina. Let's see. Liz, looks like you're up next. Liz, are you able to come off of mute?
Hello, can you hear me?
Yes, you can. Go ahead.
Excellent. Thank you. This has been very helpful, and I appreciate all the work behind it to bring us this webinar today. I'm a Napa County supervisor that previously worked at our local hospital and community outreach. I have been a member of a diverse local suicide prevention council here in Napa since 2018. The County of Napa Public Health Department has included suicide data in our current CHA and CHIP that was done in partnership with local hospitals. The data the Suicide Prevention Council has access to is being directed by data from 2021, 2022. Is there a best practice approach to access more local and current data to direct outreach in prevention and intervention? Additionally, there is also important data at our local hospitals, specifically in the emergency departments, showing both self-harm, suicide ideation, and attempts. The data I've seen in the past show a very high number of adolescents and young adults. We have submitted a request for shared data from our local hospitals, but it's been difficult to get this approval from the health system head office, which is actually out of state. Is there something the state can do to help us access that data to provide to the county's behavioral health department? That's all I have, and thank you very much.
Thank you very much, Liz. Christopher, looks like you're next on the list. Are you able to come off of mute?
Yes, thank you. Wanting to appreciate CDPH and all of your work in engaging folks and communities across the state of California as BHSA is being implemented and the 51% focused on children and youth. Really want to encourage CDPH to focus that and maintain opportunities to really support youth and children, specifically in schools. One of the potential opportunities for funding is using it in school-based health centers. And so wanting to encourage CDPH to identify opportunities for expanding and creating new school-based health centers as a delivery system. It's important that we create as many opportunities and access points for health services. As many previous individuals said, there's so many cuts right now to health services across California. And lots of health systems are having challenges being able to meet demand. And so being able to meet children and youth where they're at is really important. So wanting to encourage CDPH to investigate and see what other opportunities there are to really invest in our schools.
Great. Thank you very much, Christopher. Courtney, looks like you are next on the list. Are you able to come off of mute? I saw you come off for a minute, Courtney, but you're back.
Oh,
There you go.
there you go. Okay. Hi, I'm Courtney Armstrong. I'm the Director of Government Affairs from First Five Association, and really wanted to thank the department for moving in this direction. We really appreciate the effort to get the prevention dollars as close to the community as possible. We know there is a large shift in prevention and early intervention dollars happening as a result of BHSA, and would like to ensure that services, especially services for young children and families, are preserved to what extent is possible. We would like to urge that First Fives are required to be part of the local convenings from local health jurisdictions, and also would like to see the eligibility under CBOs expanded such that First Fives are eligible to apply. First Fives have the voter mandate to establish and strengthen the early childhood system in California, and for over 2 decades, First Fives in every county in California have pioneered many of the interventions that will be listed under the CDAPs for infant and early childhood mental health and prevention. And First Fives also serve as local early childhood experts in convening hubs for local early childhood systems, and are seen by the community as places to go for state investments and for efficiencies. So it's especially important, as mentioned in other comments, in rural and smaller communities where no coordination agency is able to serve the young children population, and also for First Fives to be able to serve as coordinating hubs for those communities. So thank you very much, and we look forward to submitting a written comment as well.
Great. Thank you, Courtney. Next up, Josefina, are you able to come off of mute?
Yes, thank you. Josefina Alvarado Mena, CEO of Safe Passages, and also member of the California Reducing Disparities Project. First, I want to appreciate the department for incorporating so many community voices into this process, and we can see it in the guidance. I also really appreciate health equity being stated as fundamental and that it will be incorporated into the behavioral health goals. But many previous initiatives have included similar language but have not achieved equity goals in implementation. So I want to put a question on the table in terms of what standards will be used in the utilization of the equity lens to measure increased access and reduction of disparities to ensure health equity is achieved within each strategy and policy area. I also want to note that although there is a lot of reference to health equity, the language is very light in terms of specific references to people of color and LGBTQ plus populations. For example, BIPOC appears only one time in the entire document. The word LGBTQ plus appears 6 times, but 2 of those times are in the footnotes. The word Black appears 5 times, but 2 times in the footnotes. The name or the API appears 2 times in footnotes only. And the Latino population is explicitly mentioned only 1 time in the footnotes. So in a time of tremendous federal erasure policy and strategies, I think it's very critical that CDPH include explicit references to these priority populations as they represent the vast majority of Californians. Also, I would encourage CDPH, and I'm very interested in hearing more about the allocation of the CBO funding towards the scaling of CDEPs, and would advocate for that funding to be greater than the amount that is currently invested at the state level. Thank you.
Great. Thank you very much, Josefina. Jason, you are next on the list. Are you able to come off of mute?
I hope so. Can you hear me?
Yes, we can. Go ahead.
Wonderful. Thank you. Jason Robison. I'm with SHARE, the Self-Help and Recovery Exchange in Los Angeles. I'm also a member of the Peer Advisory Committee. And I'm hoping that in the creation of the Office of Social Health, that community-based peer-run organizations can be included as input providers, as they are often at the intersection of connecting people in systems to community and to social supports. I'd also love to see an emphasis across our different stages on connecting all individuals to community-based self-help support groups, which is where people get social supports. And I want to thank the department for the session and the information. Thank you.
Thank you, Jason. Joseph, you're up. Ready to come off of mute?
Yes. Can you hear me?
Yes, we can.
Awesome. So my name is Joseph Page. I am the creator of the Him It Beats, a local entertainment and media, music, things like that. I've been working with clients over at the Blaine Street Clinic, and I'm a client there myself. I volunteer there. And mental health media, I'm a digital media specialist, graduated Mount San Jacinto College. And I found that recording their stories, enhancing their sound, and teaching them how to be influencers, the entertainment factor, has been a great help for the clients inside of our group. It empowers us to feel like we're somebody when somebody watches our video and says, oh, that was really good. We have one person that does voices, multiple voices. We recorded his cartoon voices. He saw himself on the video and just was so appreciative. So I'm thinking that if we can implement this program and mimic what we've been doing at Blaine Street out here in Riverside, that it will benefit multiple clients. And then also it saves them from what happens in the industry. Because if you lose a mental health dual diagnosis, such as myself, to the industry I also am a performing artist. I rap, I have albums out published professionally. And I know how to do that because of what I learned at MSJC. I'm able to do that for others, help them publish books and all of this stuff. But when the industry gets them, they will feed us as many drugs as they can. If we get fentanyl and die, they just take our art and they still publish it and make money off of it. If we teach them how to do it and offer them a program and say, but you must be clean. I've seen them come, oh, Joseph, yeah, I just want to be a part of the studio. I want to go and record. When can we get back on video? I want to go to rehab because of this. So that's just a small idea that I'd like to plant as a client and as somebody that benefits from our UHS services. Thank you so much for the time.
Thank you very much, Joseph. Um, um, Bernice, you are next. You able to come off? You able to come off a mute?
Okay, I'm in English. So, members of the Department of the Public Health of California, my name is Bernice Gonzalez, and I live in Buenaventura, and I've worked in the public organization, and she's speaking fast. Okay, so I'm a coordinator of the program and living with love, viviendo con amor. And I just want you to know that really there have been a lot of evidence that has been showing that what we are doing is based on the community. It's wonderful to be able to we have been able to help historical changes, wonderful changes in mental health. And here in California, it has just been a wonderful opportunity. Like, there's been a strategy of prevention to be working together. And here we have been able to help mental health in the area of mental health, diagnostics, everything that we've been able to do, especially with the Mexican and Latin population. In Spanish, we are able to do it in Spanish. We're able to give them linguistic access to everything that they need to be able to continue. And our strength actually has been in crisis when we are helping with urgent and emergency services and making help accessible and in our whole community. And this program has been really helpful, as we have seen, but also as we've been able to do a great amount of research here locally. We have been able to do this permanently. We want to have permanent projects from CDIP. It's very, very practical. It would be great help for us in our community of CDPs. And they're functioning for this community here. It's been at long range help. We really want this. Thank you so very much.
Hola, también voy a dar mi comentario en español. Bueno, buenas tardes, miembros del Departamento de Salud Pública de California. Mi nombre es Noemí Tungui y vivo en Tierras Chumash, en Oxnard, Condado de Ventura. Trabajo en la Organización Comunitaria Proyectos Indígena, MICOP, como gerente del programa Viviendo con Amor. Es un CITEP con el proyecto de California para la reducción de la... Agradezco que mantuvieron prácticas basadas en la evidencia definida por la comunidad en esta propuesta como una estrategia eficaz para abordar las desigualdades históricas. Y también agradezco que nombren el proyecto de California para la reducción de las disparidades a CRDP como una estrategia de prevención a nivel estatal. Aquí en MICOP nosotros apoyamos en el área estatal y violencia doméstica, sirviendo a la comunidad mexicana y latina en español y mixteco, dándoles acceso lingüístico y culturalmente apropiados para estas diversas comunidades. Actualmente apoyamos a familias siendo separadas por las violentas deportaciones y redacciones ICE. Hemos estado mirando que nuestro programa hace muy bien para esta específica población porque le estamos sirviendo en su idioma, en sus prácticas culturales y venimos de la comunidad. Les pedimos incrementar los fondos y crear un espacio permanente y estable para proyectos de CRDP, que son prácticas basadas en la evidencia definida por la comunidad que están funcionando realmente para nuestras comunidades. Y como hemos escuchado, ya hay un reporte que ha salido de la Universidad de Loyola Mount que enseña que a largo plazo ahorra mucho dinero el Estado en programas que sí sirven. Muchas gracias.
Thank you very much, Noemi. Looks like next on the list is Monica. Monica, are you able to come off of mute? Monica Zuniga, are you able to come off of mute? Oh, there you go.
Now I did. Thank you.
Yes.
Thank you, everyone. Thank you, first of all, this very useful presentation. My name is Monica. I'm a psychologist who has worked more than 9 years in a successful CDEPS program. Our work has been supported by CRDP research and evaluation, and the results have consistently shown how effective these programs are in reaching out our most vulnerable communities. So I'm definitely agree with all that have been said. The only thing that I want to add is that I'm deeply concerned that this strong partnership and programs we have built over the years could be dissolved as we are now competing for the same limited funds that once unite us. Please remember that CDEPs were created with a mission to serve communities with the least access to care, individuals without insurance, without consistent access to health services, and facing major language and cultural barriers. These programs don't just provide services, they build trust, promote prevention, and save lives. Ending or fragmenting them will mean losing years of progress in culturally rooted, community-driven mental health care. I respectfully urge you to protect and strengthen funding for existing CDEPs, to sustain what has been proven to work, and to ensure that our communities continue to receive the support, dignity, and access to care that they deserve. Thank you.
Thank you very much, Monica. Let's see. Teresa is next on the list. Teresa, are you able to come off of mute?
Hola, ¿sí me escucha?
Yes. Go ahead.
Buenas tardes.
Good afternoon. My name is Teresa Santos. I live in the city of Oakland in the county of Ventura, and I work for the organization Community Mixteco Indigenous. I'm a promoter for the well-being of domestic violence, and I am happy to hear for the best practices that are in evidence and for the community. And this proposal, like a strategy that of well-being and for the well-being of mental health, and for California, for the reduction of disparities, like the strategy of prevention at the state level. And here at the Project of Mixteco, we support domestic violence and mental health, and we see other situations like traumas, sexual abuse, suicide, separations, and families torn because of immigration. And there are situations that our communities are dealing with, and we serve our communities. We give them the support in cultural space and linguistically something that is appropriate. We give our communities, our indigenous communities, Latinos in Spanish and in Mixteco, the services that we offer, that we also give, especially because of the situations that every family is presenting. We have observed how also programs that are under investigation have shown changes that are significant under these investigations that is local and statewide. And we ask for you to lift up the funds and to create a space that is stable for the projects of CRDP that are practical in the evidences that are defined by the community, that are working for our communities, that over time saves a lot of money and gives a lot of benefit, that are social. Thank you.
Thank you very much. Martha, you are next on the list. Martha, are you able to come off the mute?
I am.
So I'm Martha Burns with Peer Support, Education, and Training in Riverside University Health Systems, and we are certified through Cal Mesa. We also get the requirements and funding for our training through Cal Mesa, and we'd like to know what, if anything, will change under BHSA, as well in general, where peer support fits in with the BHSA priorities. Thank you.
Thank you very much. Dakota, you're next on the list.
There's my microphone. Hi, Dakota Brown. I am in the Cultural Competence Department at Riverside University Health System Behavioral Health. And as a Californian, I'm so proud of the way that the state is stepping up in the midst of some appalling federal actions. I did notice on your priority populations that people with disabilities is not on that list. The DHCS focuses on the disabled population as a key population within its health equity roadmap. We know this group is historically oppressed. And then you have the intersectionality with the other minority groups. People with disabilities often were already stigmatized. And then when there's a mental health issue on top of it, it can feel like just one more thing wrong with our bodies and our brains. So I would definitely like to see people with disabilities included in the prioritized populations. And as mentioned before, they're family caregivers, the unpaid masses of sandwich caregivers who are raising kids and taking care of their aging parents at the same time. So unsung. And finally, residential facilities like nursing homes. With the privatization of nursing homes, the abuses and the corruption have just exploded. And this needs to be something looked at from a mental health viewpoint. So to recap, people with disabilities, caregivers, and residential facilities like skilled nursing units. Thank you so much for the chance.
Thank you, Dakota. Helen, it looks like you are the next on the list. Are you able to come up with mute?
Yes, I am. Thank you. Thanks for the presentation. As you said, 51% of the funds go to those under age 25, many of them in our K-12 system. Teachers, it's been noted in many surveys, are trusted messengers and in fact rank up at the top with nurses, for example, as trusted messengers. And so I wanted to ask whether the grants that are available for trusted messengers are going to be open to schools. I see you list CBOs. I'm not sure whether you qualify. They would qualify as a CBO. And would just want to know, I see LEAs, local education agencies, are included as one of the groups that will be coordinated with. But could you give some more details on how this will happen? There are 1,104 school districts in California, so it would be very helpful to know. I see that your Office of School Health is on this, and they're just a wonderful resource. So I'm hoping you can use them to do this. But really, on the funding issue, I don't see, and maybe you can correct me, where there's funding available for schools. Thank you.
Thank you, Helen. Seon, you are next on the list. Are you able to come off of mute?
Yes, hello. My name is Seon Bihaloli Pubin. I'm the County of San Diego Public Health Officer. And I just wanted to make sure if I'm guessing you all very aware of this resource, but the CDC just very recently in the last couple of months put out a Engage product, which I'll put in the chat. But it really looked at the evidence in terms of what types of interventions and what strategies work in terms of preventing youth substance use. And just wanted to recommend this as a framework when we're thinking about, how to build out this plan and program and identify the needs. And of course, I agree with so many of what everyone said in terms of cultural competency and including the right people, lived experiences, voices, peers, etc. But I just want to make sure you have this. And then the person who actually led the team at CDC actually is no longer with the CDC and is in California and is probably available if you all need to tap into it. I know he's helping with some marijuana efforts with the state as well. Over. Thank you.
Thank you very much. Katie, you able to come off the mute?
Yes. Hello. Katie Weber from the Institute on Aging. Appreciate you guys holding this webinar and the opportunity to give public comment. I think it's really important for us to focus on kind of the upstream support, stigma reduction, and meeting older adults where they are. And the Institute on Aging has a warm line called the Friendship Line, which the state has been supporting for many years. And we really see this as a population-based prevention strategy. Many older adults don't feel comfortable accessing traditional behavioral health systems. And so I think it's really important to see these warm lines. I know warm lines are mentioned in the guide, but more specifically focusing on older adults as a way for them to have a connection to the behavioral health system without necessarily seeing themselves with specific behavioral health diagnoses. And I think that overall, it fits in well as a example of the kind of social and behavioral health interventions that can exist from a broader population prevention perspective. But overall, just wanted to say thank you for including older adults and the importance of warm lines.
Thank you, Katie. Stacy, are you able to come off of mute, Stacy?
Yes, thank you.
Go ahead.
Thank you. Just took me a second. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. I really want to thank the department for conducting this and providing so much time for public comment. And Jonathan, you're doing a great job too. Thank you. I just want to say that people have been asking me, well, gee, how do you think, about this part phase 2? And it's hard for me because it is very detailed, which is nice, but some of the detail, such as how the pots, for example, the CBO category or the other large categories will be broken out, within that category, the funding, how will it be broken up? As far as the report, I want to bring out on page 10 for just an example, the table of focused set of strategies and the programs listed below. I totally understand building upon what is already in motion or operating, but I am concerned that some or many of the programs listed, we do not know how well they serve BIPOC and LGBTQ communities because they either don't, collect data, or we frankly already know that they are not serving LGBTQ and BIPOC communities very well. I mean, if you look at the table on page 11 of the allowable activities, yes, there is one among those 20 bullets that say traditional healing practices and community healing circles, but many of the other activities listed do not serve BIPOC and LGBTQ communities well. So I just want to point that out. So when I'm not sure, I do appreciate that the community-defined evidence-based practices are listed in this same section, but it's a little bit difficult for me to figure out how these are going to all be combined. And if, again, you're building upon programs that are already existing, I hope that it will be taken into consideration how they are serving our communities. And then the other thing, and on page 14 again, listing existing campaigns that may. Oh, I'm sorry. Did my time run out?
It has. If you want to conclude your comment, though, that's fine.
Okay, I just on page 15, I am concerned about the bullets under the suicide and self-harm statewide education and awareness campaign. The API community has met in the past with the Department of Public Health to register our concerns about how some of their suicide projects have not accurately represented the API community, and I questioned some of these bullets on page 15, and just want the department to be careful about proceeding with the suicide prevention. Thank you.
Thank you, Stacy. Ellen, you're next on the list. Would they come off of mute, Ellen?
Yes, can everyone hear me?
We can. Go ahead.
Hello, everyone. My name is Alan Mora Lopez, and I serve as a program coordinator for Latino Commission. Our organization is dedicated to provide mental health services, substance use prevention services, and substance use prevention services throughout the Coachella Valley. Our work is supported right now through the funding from Riverside County, but as the county is transitioning its funding structure to align with Proposition 1, support for the prevention programs is scheduled to conclude June 30th, 2026. So this change will not only impact the dedicated community workers who deliver these services, but it will also create a gap in access to the evidence-based prevention programs that have been making a real difference in the lives of the families across our community. The program I coordinate is the Strengthening Families program, which brings parents and children together to share a meal, learn communication skills, life skills, and build stronger, healthier family relationships, ultimately helping uplift the entire community. We remain hopeful and committed to ensure that there's a seamless transition so that vital programs like the Strengthening Families program continue to receive support under the new funding structure. That is all. Thank you so much.
Great. Thank you very much. All right. Next up is Erica. And as Erica is unmuting, I just want to mention we are at 12:20 right now. We have about 5 minutes left in public comment. We have, I think, 5 hands raised. I apologize in advance if we're not able to get to everyone. Please remember some of the other ways to share comments with CDPH. And with that, I will turn it over to Erica.
Thank you. I'll try to be brief. So hello, my name is Erica Jun. I'm with Special Service for Groups Research and Evaluation. I've worked with the California Reducing Disparities Project, the CRDP, for the past 10 years. I wanted to thank CDPH for today's presentation and the investment in this public comment period and process. We really appreciate that you are open and listening to all of the communities that are out there. I appreciate the expressed desire to incorporate health equity and prioritize various at-risk populations and community-defined evidence practices, CDEPs, within the draft Phase 2 guidelines. I think it will be important to think through how those with highest need and at greatest risk for negative outcomes, as mentioned in the draft, are identified and engaged. Whether they are getting effective services in a culturally responsive manner that includes language needs by trusted community experts, and then what evaluation or accountability measures will be put in place to ensure that there is, in fact, health equity in practice. Thank you.
All right. Thank you very much. Unfortunately, we just lost all of the hands that were raised. Lupita, I believe that you were next on the list. I am just scrolling through right now, trying to find you.
Yes, I'm unmuted.
Okay, great.
Hi, my name is Lupita Rodriguez. I am with the Health Education Council, and our program, Mente Sana Vida Sana, is funded through the CRDP, of which I have been a part of since we started it. And I just want to echo the previous comments on the more robust and intentional mention of BIPOC and LGBTQ populations in the guidelines presented. And I do want to thank CDPH for calling out and highlighting CDEPs in the guidelines that were presented. Thank you.
All right. Thank you, Lupita. Leo, I think you're next. Are you able to unmute?
Yes, thank you so much. I appreciate you taking my comment. I'll do mine in Spanish. Mi nombre es Rio Lorenzo y soy una persona mixteca indígena de la comunidad New Savvy People of the Rain, Pueblos de la Lluvia, que reside en Oxnard, en el condado de Ventura. Trabajo en la organización comunitaria Proyecto Mixteco Indígena, MICOP, y como directora de bienestar superviso varios programas de salud mental, incluyendo el programa Viviendo con Amor, del cual han escuchado. Les agradezco muchísimo por mantener estas prácticas basadas en evidencias definidas por la comunidad en esta propuesta como una estrategia eficaz para combatir las desigualdades al acceso de salud mental que nuestras comunidades afrontan en su diario vivir. Nuestra organización proporciona servicios con acceso lingüístico y contenido culturalmente relevante que ayuda a comunidades indígenas no solo a sobrevivir, pero a progresar. Esto creo que es clave. Estamos ayudando a nuestras comunidades a existir. Proveemos un espacio seguro con el cual se identifican y en el proceso ayudamos a reducir los instantes de depresión, ansiedad, ideación suicida, sentir de no pertenecer y demás temas que como seres humanos presenciamos todos. Es enormemente importante poder retener estos recursos vivos ya que no existen suficientes recursos, especialmente con el clima político que nos estamos afrontando. Existen personas tan vulnerables ahorita que se están escondiendo, viven con miedo y todos merecemos poder vivir en paz. Y esto incluye a nuestras comunidades indígenas. Mi pedir es que por favor incrementen los fondos para crear un espacio permanente y estable para estos proyectos de CRDP, que son prácticas basadas en la evidencia definida por la comunidad que están funcionando para nuestras comunidades indígenas y que a largo plazo en verdad nos está ahorrando muchísimo dinero al Estado. Les agradezco muchísimo que me hayan dado el tiempo.
Over time, it's saving us a lot of money to the state, and I appreciate you very much. Thank you.
Thank you very much, Rio. Looks like Erica is next on the list. Erica, are you able to come off of mute? Erica, are you there?
Oh, I think I already spoke, so I don't know if that was an accident. Yeah, thank you.
Great. Yes, thank you. All right. And then do we have Leticia? Okay. Yeah.
Yes,
Sarahi
good
and then
afternoon.
go ahead.
Thank you very much for this time. I had placed it in the comments because I thought that I wasn't going to get to it, but my name is Leticia Galicia and I live in the county of Ventura. I work in the organization for the project of Mixteco Indigenous MICOP, like promoter, interpreter in the language Mixteco in the area of Oaxaca, Puebla, in Mexico, and I work like a promoter.
Trabajo como promotora y
And
navegadora
with the
de
well-being,
salud
mental
mental y
health,
violencia
mental
doméstica.
health and well-being.
Les
And our
agradezco por mantener
practices based on
prácticas basadas
evidences
en
defined by the
evidencia
community
definidas
in
por la
this
comunidad
proposal,
en esta
like a good
propuesta
strategy
como una
to
estrategia
be able
eficaz
to
para
take them
abordar
on
las desigualdades
historically in mental
históricas
health.
en
And I
salud
also
mental.
appreciate
También agradezco
to name the project of
que nombren
California
el
to
proyecto de
reduce
California
disparity
para reducir
and like a
disparidades
strategy of
como una
prevention
estrategia de
at
prevención a nivel
state
estatal.
level.
Aquí en
And
el
here
proyecto
in the program
Mixteco
Mixteco,
apoyamos en
we've
el área de salud
worked with
mental y
domestic
violencia
violence and mental
doméstica,
health, serving
sirviendo a las
indigenous
comunidades
communities in 4
migrantes
regions
indígenas en
of
las 4
Mixteco,
regiones
of
de
Mexico,
Mixteco
in Spanish
de México,
mainly.
en español.
And I
Mayormente
support
yo
the
apoyo a la
community.
comunidad de
And
habla
in the
mixteco, ya que en
county
el
of
condado de
Ventura, there's
Ventura
a
hay
big
un gran
number
número de nuestra
who
comunidad
speak Mixteco
hablantes
in
mixtecos
different variants.
en los diferentes variantes.
And also,
También
we have this
pues tenemos
linguistic
ese
access
acceso
that is
lingüístico y culturalmente
appropriate. Now that I
apropiado,
come
ya
from
que
the
vengo de la
community, I was
comunidad,
raised in the
fui
community,
criada
I
en la
know the language
comunidad,
and the
conozco el
culture, and
idioma y la
that's why our
cultura,
service
y es por
in our
eso nuestro
communities.
servicio a nuestras
I
comunidades.
also
También
appreciate those
agradezco
programs that are
estos
also
programas que
functioning the way
están
that we've
funcionando
seen,
como hemos
but
observado,
also
pero
the
también
way it's
como lo
shown
demuestra nuestra
our
investigación
community,
local y
local,
estatal.
and
Les
statewide.
pedimos
I
o le
also
pido en
ask
nombre
the
de la
Organization
organización
for
y de nuestra
Community
comunidad
Indigenous Migrants
indígenas migrantes
that the
que
funds to create a
los
permanent
fondos y que
space
creen un
stable
espacio
for the
permanente
projects
y
of
estable para los
CDRP that are
proyectos de CRDP,
practically
que son
evident
prácticas
based on
basadas en
evidence
la
defined by
evidencia
our community.
definida por nuestra comunidad.
CDP
Del
that is
CDP
functioning for
que
our
están
communities,
funcionando para
and
nuestras
over a long
comunidades
time
y que a
it'll
largo
save the
plazo
money to
ahorrarán
the state
dinero al
and
Estado
it'll
y
benefit
beneficiarán
our
a nuestra
indigenous
comunidad
community.
indígena
Thank you.
migrante. Gracias.
Great. Thank you very much, Leticia. All right. Great. Thank you very much, Leticia. All right. I am going to ask to go to the next slide and pass it back to Trudy to wrap up the day.
Right. Thank you, Jonathan. And thank you, everyone, for all of the incredible comments. Your insights are really what is going to help us inform how we operationalize all of these things and just ensuring that we keep all of these comments in mind for the future. So thank you for joining us. Thank you for staying with us for the last 2 hours. I especially want to just acknowledge and applaud those of you that provided your comments in Spanish and just your willingness to participate in this process. It was incredibly meaningful and important for us. So in terms of next steps, just note that we will be closing the public comment period at midnight on December 2nd. We will need to take some time, just given the breadth of depth of feedback and comments that we've heard, but we will take the time to analyze and synthesize all of the comments, both those provided today orally as well as any written comments, and ultimately incorporate into what I had mentioned before, which is our final BHSA Population-Based Prevention Plan, which will incorporate both Phase 1 and Phase 2 as part of this process. And so if you have any additional questions, please do not hesitate to reach out to us. You will see our inbox information here. Your input, your feedback, your questions really are going to help us drive how we operationalize all of these things, but ensure that it's meaningful for the community and for those that we serve. So with that, just a huge thank you again, and just 1 minute over. So please enjoy the rest of your day. Thank you.